Thank you, Dr. Umang, and I really want to thank Dr. Umang and others involved in this instruction course for giving me the opportunity to present here. So keratitis is always a challenge, we all know that. There was a 62-year-old male who presented at one of our peripheral centers with complaint of pain, redness, photophobia in both the eyes since 2 months. So when he presented there, he was really in pain so much that he could hardly open his eyes. And at presentation, he was on systemic antibiotics as well as topical antibiotics, eye drops. So if I just look at both the eyes, it was like a bilateral involvement and the patient was aggressively losing the sight. So if you look at the right eye status, there is this peripheral perforation which is present, and at the peripheral center, at that point, the immediate thing which we could do was a resection and gluing that patient. And in the left eye, there was actually if you look at it, a large, around 2 clock hours iris prolapse which was present. So all peripheral. But if you look carefully onto it, the sclera remained uninvolved and the patient was actually losing sight or had lost most of the sight and could see very little at that time. So at that point, the question was, what are we dealing with? Are we dealing with an essential local pathology or a systemic problem? Obviously, our patient transferred to the main center, where we did all the systemic investigations which we wanted to do for this patient. And with the systemic investigations, as a diagnosis of exclusion and sclera not being involved, and the clinical picture of the ulcer, a bilateral Noren's ulcer diagnosis was made. But again, it was a bilateral perforation, and immediate intervention was needed to save the eye. So a patch graft with a conjunctival resection was planned for the patient. So if you just look at it, this is the right eye photograph where we were doing the patch graft, and corneal tissue was, a freehand dissection was done, where a conjunctival resection, which I would again stress was quite important here, where we did the whole of it, the conjunctival resection, and a freehand graft was placed on the perforated area and interrupted sutures given as is advised in such a case. Along with that, this was the end of the surgery where we could give just a tectonic support. This is for the other eye. Again, like a freehand dissection, but the only thing which we felt at that point that the tissue was very edematous. We wanted to give tectonic support, so we did some lamellar dissection of the tissue as well. So if we look at, this was the final picture post patch graft for both the eyes. The patient was definitely, this was done under high dose steroid cover, and injection methylprednisolone was given IVI monitoring 2 doses with physician's approval. Tablet prednisolone 60 milligram was continued with topical prednisolone eye drops, a tear substitute and a cycloplegic and a prophylactic antibiotic eye drop. After which the patient was following up in the peripheral centers, and definitely the sutures loosened and there were a lot of things, but they were managed as and when required. The resuturing and things were done. Now the next question was, when the patient came 10 weeks later, it was a relatively pretty quieter eye at that point. So this was the right eye status at that point. The patient was completely saying that now I just can't see. So if we look at this right eye, the cornea, if you see, there is a Descemet's detachment which we could see that it might be there in the cornea, which was there superiorly if you can look at the picture. And then this was confirmed by the ASOCT which was done for this patient. This is the right eye. If you go to the left eye, this is how it presented. There was a mature cataract, a very shallow anterior chamber and peripheral thinning. Now visual rehabilitation is what the patient is expecting. Whatever you do, you have to give them vision, that's what they'll come back to you. So again, we had to do something. For the right eye, air descemetopexy was done, where the descemets was tried to be put back on the place, and which was proved. If you look at the ASOCT, yes, the descemets did attach back. And this is around a 4 days picture where the cornea is looking relatively quite clear. So the other eye, a cataract extraction with a keratoplasty was planned, but this time we had to be sure because this all had to be done within a couple of days, one after the other. 3 doses of injection methylprednisolone were given 3 days consecutive prior to the surgery, like loading them on and immunosuppressing them. And this is the post-operative picture where a cataract extraction and keratoplasty was done. As you can see, this is a large graft which had to be taken. It was not easy because the whole of the periphery had thinned out, and practically the scleral area or the whole area had to be just reinforced so that you can just pass the bite on the steroid. The patient has now been planned on a maintenance of injection cyclophosphamide 2 mg per kg at monthly intervals, prednisolone in tapering dosage till the time the cyclophosphamide takes its action course, and topical steroids continued and systemic monitoring. And this is a right eye picture, so both eyes could relatively be rehabilitated and the patient is doing fine as of now, but again, follow-up is what is required. So here was this another case who came actually before this case. It was a 62-year-old male who presented with a 3 months history, and he was on treatment and was on steroids. So it was probably diagnosed that we were dealing with some inflammatory problem. The patient was on the systemic investigations were normal. If you see in this photograph, there is this area which is looking pretty active, where the rest of it is quite vascularized. But if you look, it just looks like the iris has come out. But actually, if you look at the slit picture, it is the descemetes which is there. So it is a large descemetocele which is there. So what to do in such a case? Actually, there is descemetes which is already present. So a tag under the steroid cover was planned. So you remove the descemetes membrane, and again a freehand dissection is what is actually done here in this case. So 2 stay sutures were given, and after that the whole suturing was done. One thing which I learned from this case that maybe what we talk about Dua's layer, it is actually a very tough layer. The whole surgery went on and there was no perforation, it was just like an extraocular surgery. And post-operatively, the patient was on high-dose systemic steroids with eye drops of steroid and topical antibiotics and tear substitutes. 2 weeks later, the patient was doing fine, and we were all pretty happy that it's doing well. And if you see, the whole cornea looks pretty attached, and it's looking like a stable cornea, and the patch is doing okay. That's what we had planned at that time. If you look, suture removal done as and when it was required, and 6 weeks later it was pretty okay, but this was not the end. 9 weeks later, suddenly he comes off with this, again, this is a retracting patch graft which is happening. We were all quite lost, what has happened. The only lesson which I learned from it, maybe at that time, conjunctival resection was not done as along with that patch graft, because the eye looked pretty quietly. Maybe that was the reason why it was retracting and there were some inflammatory cells which were coming. So because this patient came before, so the next patient when it came, this was the first thing which we did, 360 degree, remove the conjunctiva and fill it up. Patch graft has been done for this patient, and the patient is doing well, but he's systemically not okay right now, and he couldn't come for follow-up, so we don't have a picture of this patient after that. So if we talk of Murum's ulcer, it is a distinct entity, but its diagnosis of exclusion. Other causes of peripheral ulcerative keratitis should be ruled out, such as infection, collagen vascular disease, and degenerative processes. Because of immune system remarkable memory, surgical attempts should be done only with concurrent immunosuppression, even when the active disease has been arrested. And attempts at penetrating keratoplasty are often associated with recurrence and graft failure. Even if it is quietened out, you can never be sure that you're going to be without surprises. So if you just go at, this is another case of aggressive movements where there was again a descemetes detachment in a quiescence phase, and we did a descemetopexy and it did well. So aggressive movements, you have to treat them more aggressively, as we said, and this is the regime which is usually followed with aggressive movements. And this is just a week back photograph of a patient, bilateral movements coming back. One eye had a failed PK melted. This is a post-conjunctival resection and TABCL which has been done for this patient. Maybe the next time when we meet, I'll be able to give you the follow-up of this patient. It's just a week back which we did. And so I would just say that timely detection and early intervention is the key to successfully treat aggressive movement ulcer. Immunosuppression remains an important adjuvant, and treatment is hand in hand with physician, and we need to take them on a close follow-up, and a long-term care is what is required in these patients. Thank you very much.